A very good morning to all of you. Welcome to another episode of Free Knowledge Academy Weekly Sunday webinar series. Today we have a very interesting topic, update on the diagnosis of tuberculosis. Before moving on to today's lecture, let's go to see some housekeeping rules. The webinar link will be open for you to join in from 9:15 to 9:45 a.m. No late attendees will be permitted to enter thereafter. We have to stay until the end of the lecture to obtain the CPD points and the CPD certificate. The link for the CPD certificate will be posted at the end of the lecture. If you have any questions, you can ask at the end of the lecture. Kindly keep your videos and mics turned off during the time of the lecture. Before moving on to the lecture, let's go to introduce today's lecturer. Today's lecturer is Dr. Wathsala Dayanthi Galagedara, who's a consultant microbiologist currently working at National Tuberculosis Reference Laboratory under the National Program for Tuberculosis Control and Chest Disease. She graduated from the Faculty of Medicine, University of Colombo in 2009 and has been working as a board-certified specialist in medical microbiology since November 2021. Dear Madam, thank you for joining with us today, and over to you to conduct your timely lecture. Thank you.
First of all, good morning to you all. Thank you very much, the organizing committee of SRI, for giving me this opportunity today to talk about this important topic, representing the National Program for Tuberculosis Control and Chest Diseases. So in this 1 hour talk, I would brief about the background of tuberculosis, like modes of transmission, some terms that will be useful which will you encounter during this talk, and TB infection versus TB disease, and TB diagnosis services in the country, and laboratory diagnosis of tuberculosis in detail. So this might be sometimes this might be, you may find it boring, but at the end of the lecture, please feel free to ask questions, so I will try to clarify things as much as possible. So as you all know, tuberculosis is an airborne disease, so it transmits through aerosols. So it is caused by mainly Mycobacterium tuberculosis, and there is mainly Mycobacterium tuberculosis and 7 other very closely related mycobacterial species. We call it Mycobacterium tuberculosis complex. So the importance is these pulmonary TB patients serves as reservoirs for this MTB complex. So it is very important to rapid diagnosis and start appropriate treatment as soon as possible to prevent the spread. So that's why that is the main purpose of this whole talk is about today. So some terms, TB disease versus TB infection. So you must be aware that all patients, people infected with tuberculosis do not get the TB disease, active disease. So it is said near 25% of the world population is infected with TB, but only 5 to 10% will develop TB disease over their lifetime. And this TB, people with TB infection, we define it as persistent immune response to Mycobacterium tuberculosis antigen with no evidence of clinical manifestation of TB disease. So in these patients, the people with TB infection will not have any signs and symptoms of TB disease. The chest X-rays will be normal or static. And if they are tested with microbiological tests, those will be negative. So that is TB infection. So I'll be talking in detail the diagnosis of TB disease and some facts about diagnosing TB infection as well at the end of the lecture. So another terms, few terms that we need to know: drug susceptible TB versus drug resistant TB. So there are main four first line drugs that treat TB, tuberculosis: isoniazid, rifampicin, pyrazinamide, ethambutol. So we call drug susceptible TB when the strains are strain of infecting tuberculosis is not resistant to either isoniazid or rifampicin. Rifampicin-resistant TB, we call it RRTB. So it can be either molecular genotypically tested or phenotypically tested. So we call it's RR, rifampicin-resistant TB. So that is also called as surrogate mark of MDR-TB. So when isoniazid and rifampicin are both resistant, we call it MDR-TB. So this rifampicin RR-TB and MDR-TB are discussed together. So there are another two terms, pre-XDR-TB. That is when both isoniazid, rifampicin, and additionally resistant to fluoroquinolone, either moxifloxacin or levofloxacin. XDR-TB is when MDR-TB plus resistant to either moxifloxacin or levofloxacin, plus at least additional group A drug. Group A drugs are either linezolid or bedaquiline. So in Sri Lanka, this drug-resistant TB is not that much of a problem yet. So there had been around 30 cases of drug-resistant or RR-resistant TB, and there had been one XDR case, but not that much of a problem as for now. So TB disease mainly discussed as pulmonary TB and extrapulmonary TB. So most frequent site of involvement is, as you all are aware, it's pulmonary TB, where the lungs are involved, it's 80%. And when it occurs outside the lung, it's called extrapulmonary TB. So extrapulmonary TB, the most frequent sites are lymph nodes and pleura. And it can occur TB can occur in any system of the body, musculoskeletal, central nervous system, anybody. And you might be knowing that it is a great mimicker. It can mimic malignancies. So it is very important to send the appropriate sample for correct diagnosis. So some facts about Sri Lankan situation. Tuberculosis reports the third highest incidence and the second highest mortality among infectious disease in Sri Lanka. So fortunately, Sri Lanka is still a low burden country, and estimated TB incidence of Sri Lanka is 64 per 100,000 population in 2021. So this is from the national program, the data. So as you can see, the case detection is increasing. All TB, EP, extrapulmonary as well as pulmonary TB. So there had been a dip in 2021, 2022, probably due to COVID. Now it's increasing, and we are expecting more so this is 2023. We are expecting more in this year. So we have receiving a lot of samples to NTRL. And this is the distribution of cases in the districts within the country. So, sorry, I have missed, I think it's the Colombo, Gampha, Kalutara are the, I'm not sure whether it's visible correctly. Colombo, Gampha, Kalutara are the most with high disease burden, probably due to the increased population density. So as I said, National Program for Tuberculosis Control and Chest Diseases in the Ministry of Health is the institution, the program responsible for tuberculosis control in Sri Lanka. So the National Tuberculosis Reference Lab, where I work, is under the NPTCCD. So this is the organizational structure of the NPTCCD, or the national program, comes under the DDG Public Health Services. So National Tuberculosis Reference Laboratory, Gampaha Chest Clinic and Colombo Chest Clinic comes directly under the program. Whereas the other district chest clinics dispersed in all over the island, 26 district chest clinics comes under provincial health PDHS and the relevant RDHS. So TB diagnostic services, this is the laboratory network. So the NTRL or the National Tuberculosis Reference Laboratory is in the top of the network. And there are 4 intermediate TB culture laboratories in Jaffna, Ratnapura, Galle and Kandy, where they do cultures, TB cultures. And gene expert is also available there. And when there is a TB, there's a growth, when the TB bacilli is isolated, the isolates will be transferred to NTRL for drug susceptibility testing. And there are 29 gene expert testing sites. I will discuss in detail later. And 26 district chest clinic laboratories, where in some district chest clinic laboratories, gene expert facilities available and microscopy facilities. This 160 microscopy centers, this can be once, sometime the number varies. So there will be new microscopy centers appearing with the PHLTs working. So we will have microscopy facilities there. So this is the diagnostic algorithm for tuberculosis published by the program in 2019. Here it says, in patients with signs and symptoms suggestive of pulmonary TB, so the first, main mode of investigations would be chest X-ray plus sputum, FB3 smears. If the SB is negative only, asked to go for gene expert, but the WHO guidelines are changing. Their recommendation is to go for chest X-ray and the gene expert as the initial test. So laboratory diagnosis, they recommend a gene expert as the initial test. So there is, by the program, they are going to pilot it in the first in the Colombo and the Western Province, and then gradually to other districts as well. So when it comes to TB diagnostic tests, so we can, for the convenience of discussing, we can categorize them to few groups. So conventional diagnostic test for diagnosis of TB. So the test we know from our medical student days, sputum microscopy and TB culture. They are solid and liquid, we say. And here then comes this WHO recommend rapid diagnostics. They are the new test. We call it WRDs in short. So these can be categorized into tests which detect drug resistance and tests that cannot detect drug resistance, and also another group. So this is drug resistance means mainly rifampicin. They talk about rifampicin. Test to detect additional drug resistance. So I will discuss in detail. So so when we discuss about laboratory testing, sample collection and transport is very important. So this first containers is for microscopy. We tell wide mouth clean container. So this first yogurt, it's like the appearance of a yogurt cup. This is replaced with this second blue top container, which secured with a screw capped lid. So these are not sterile actually, they are clean containers. You can send samples in these containers for sputum microscopy, but please remember, if you want to do gene expert or molecular test or culture, you have to send in sterile containers. So we can't perform those tests when sent in these first two containers. And that applies same to both sputum and extrapulmonary samples. And the important thing is, if there's a delay in transport, For TB samples, you have to refrigerate in 2 to 8 Celsius if there's a delay in transport. So this I have taken from the NPTCCD manual. So it is everything available in detail in the NPTCCD website. So every laboratory test, there's a saying, garbage in, garbage out. So we need a good quality sample to produce a good quality report. So this is the TB6 form. It is very important to fill this form clearly and accurately and conventional diagnostic test. So this is well-known sputum microscopy. So this is, as you can see, the nice pink elongated rod-shaped acid-fast bacilli in the blue background you can see. So this is a very old method, least expensive method, which matches our low-income countries like ours. But the disadvantage is, you can see level of detection for sputum microscopy to become positive, there need to be 5,000 to 10,000 bacilli per ml. So this sensitivity is low. That's why we asked to collect 3 consecutive samples, sputum samples. So spot sputum sample on day 1, and we give a container to the patient to bring on the second day. And second day early morning sample plus second day spot. So there will be 3 samples for the convenience of patients. With 3 samples, we can increase the sensitivity to more than 90%. And the disadvantages would be that we can't differentiate between MOT. MOT means mycobacterium other than tuberculosis, because they will also stain with acid-fast stain. And these and the results will depend on the staining technique and the experience of the microscopist. And because I mention it here, I will mention that Sri Lanka has a very good system of external quality assurance of sputum microscopy. The NTRL monthly randomly get down certain number of slides to NTRL from all the 26 district test clinics, and also some hospitals and some private hospitals as well. And they are checked by our experienced PHLTs, and we issue a report. So even though this is a less sensitive method, so this external quality assurance is assured. And the other disadvantage is that obviously we can't detect drug resistance with sputum microscopy. So mycobacteria culture is considered another conventional method, but it is the gold standard with sensitivity and specificity. As you can see, only 10 viable bacilli can be because we culture the organisms, can be detected in culture. So these are the culture methods we use. There are 2 types of culture method, egg-based and agar-based. So what we used in NTRL is this Lowenstein-Jensen or LJ medium. Sorry, this middle group should come to the other side. So LJ medium, so if you can see this nice blue color culture media. So this is we prepare in-house at NTRL, and for this we are purchasing for about 400 eggs per week, every week. And this is another method, both solid culture and liquid culture available at National Tuberculosis Reference Laboratory. So we have this automated system with liquid culture. So the system we have is BD Bactec Midget at NTRL, which can inoculate 960 samples at a time. So the mechanism is continually monitor the media for detection of mycobacteria for 6 weeks. So when compares both liquid culture and solid culture is expensive, takes 6 to 8 weeks. But liquid culture, of course, is more sensitive, increased because of the culture media. And but the disadvantage is the contamination rates are high with liquid culture than solid culture. And with while it takes 6 to 8 weeks for solid culture, liquid culture, we can give results. Average duration is 12 to 16 days. So what happens in NTRL is, so we do have both the culture methods. So we do sputum. The sputum goes for solid culture, and the extrapulmonary samples, all the extrapulmonary samples except urine and bone marrow, it goes to liquid culture. So the purpose of mycobacterial cultures, so both these culture medium growth, Mycobacterium TB complex, and also non-TB mycobacteria or mycobacteria other than TB. So some word about this MOT or mycobacteria other than TB. Unlike MTB complex, these MOT are common environmental pathogens. So detection of MOT in a culture should be interpreted clinically, and of course, they can cause opportunistic infections in certain patient groups. So this is a picture of MOT growing in LJ medium. So this is the molecular test or the newer test, rapid test, I'm going to discuss in detail. So WHO recommends this to do this molecular test as the initial test to increase the case detection and to increase the sensitivity of the test. So they can be categorized as tests with drug resistance detection and without drug resistance detection. It's mainly rifampicin. So we do have in Sri Lanka, we do have this MTB, expert MTB reef established since 2014. And so I will show you the map that the gene expert machines are available in almost all 26 districts. And this TrueNat is a newer addition. So TrueNat, I will discuss. So these are the pictures of these so-called machines. So this expert MTB reef is it's a cartridge-based automated test. We call, in short, CBNAT, cartridge-based nucleic acid amplification test. So it's a type of PCR which detect MTB complex plus rifampicin resistance in a one go. So we can give results less than 2 hours. So this is the small the machine. It's not that big, and you can see this cartridge we purchase. So there are 4 modules. If all the 4 modules are working, we can do 4 tests per run. So the current WHO recommendation is to do Gene Expert as the initial diagnostics test in all adults and children with signs and symptoms of pulmonary TB. And also, Gene Expert is recommended to do in selected extrapulmonary specimens like CSF, lymph nodes, and tissue specimens. So this is initially it was expert MTB reef, but now all the cartridges we are getting is Ultra, Gene Expert MTB reef Ultra. So this is a highly sensitive test with, you can see this detection limit is 16 colony forming units per ml compared with the sputum. If you can remember, it was 5,000 to 10,000 bacilli need to be there to detect by sputum microscopy. So results are available in less than 80 minutes. So this is how you can see a report of Gene Expert. So MTB, we MTB detected, so we will give the amount, high, medium, low, very low, or trace. So, and the RR, rifampicin resistance status, detected, indeterminate, or not detected, or it can be a MTB not detected. So there will be no RR, rifampicin status result. So with this, guys, you might have seen, if you are in Vault setup, there are reports with gene expert detected trace. That means it's a very small amount of TB bacilli. So what WHO says is, in children and in people living with HIV, if this and also for EPTB samples, so this M. tuberculosis complex detected trace means to take it as bacteriologically confirmation of TB. And please remember, when there's a trace result, you will not get results on rifampicin resistance. So we will need additional tests like culture and DST to detect rifampicin resistance. So as I said, this is you can see all these, you can find all these details in the NPTCCD website. So gene expert machines are dispersed all over the country. There may be issues with module dysfunction and machine dysfunction, but at the moment, so this map is like this. And so this is, as I said, so if you
maybe chicken banana or gain.
So if you consider the same thing I said, so when there's MTB detected trace for extra HIV, so they take it as bacteriological confirmation of TB. But when in a sputum sample, if there's no evidence, they are not at risk of HIV and who have a history of prior TB and also whose TB treatment ended less than 5 years ago, WHO recommends to reevaluate it because it can generate false positive trace results. So some word about TrueNAT machines. This has not been implemented in Sri Lanka yet, but we have 17 TrueNAT machines, which Health Ministry has got as donations for COVID testing. So the TB program is trying to relocate these machines and take them for TB testing. So but unlike Gene Expert, this TrueNAT, only sputum specimens are recommended at the moment. And the limit of detection varies from 30 to 100. So it is less sensitive than MTB Ultra. And the advantage of this is it can be battery operated and minimal infrastructure. So the WHO recommends to place these TrueNAT machines in more peripheral laboratories. So in the future, the TrueNAT machines will be redistributed, and you can test sputum with the TrueNAT as well. So WHO recommends for TrueNAT, the WHO recommendation is to use as initial diagnostic test for TB rather than smear microscopy or culture. So this is just for the completeness sake. Either of these tests are not available in Sri Lanka. So the TB LAMP assay is a type of gain molecular test. Loop-mediated isotomal amplification. This is, but it cannot detect drug resistance. Urine LF-LAM or lipoarabinoid assay is a test that is recommended. It can be tested with urine, recommended to use in HIV positive individuals, especially in urgent cases where rapid TB diagnosis is critical for patient survival. So that is not very sensitive, but it is recommended. But neither of these tests not available yet in at NTRL. So as I said, it's just like a summary. So the first two tests we have in Sri Lanka, Expert and TrueNat. The other, then again, we have this Expert Expert XDR and the line probe assay. I will discuss in the next slide. So this is only available at NTRL at the moment. So this is the same machine with some technological advancement. We can detect, so the rifampicin resistance can be detected from the GeneXpert Ultra. For this, the other resistance to isoniazide, fluoroquinolone, ethionamide, and aminoglycoside can be detected with this XDR assay. So at the moment, it is in operation at NTRL. So this is again the test that can detect isoniazide and rifampicin. This with lot of these several trade names: Abbott, real-time MTB, RIFI, NHBD, Max, Brucahain. These are not available in Sri Lanka in NTRL, but we are able to detect isoniazide and these other 4 drugs I mentioned with the Expert XDR assay. So this is again a very laborious test, line probe assay. So it actually from these first two, it serves the main purpose. Detects, we can detect first line resistance and second line resistance to rifampicin isoniazide and the fluoroquinolone and aminoglycoside. And the added advantage is with this machine, we can speciate the MOT. What means the mycobacteria other than tuberculosis we can speciate, but unfortunately it was out of order last year, but we are planning to restart. So there are a lot of when the MOT or mycobacteria other than tuberculosis are significant, we can speciate if we function this. Again, so the same things I mentioned, diagnosis of extrapulmonary samples. So tissue biopsy, tissue aspirates, past CSF, we can do GeneXpert, Ultra, and TB culture. Pleural fluid is not recommended by WHO to do routinely GeneXpert with pleural fluid, because to diagnose pleural TB, the best specimen is, they say, pleural biopsy. So it's better to go for TB culture if pleural fluid. And urine and bone marrow, as I said, goes for TB culture. The blood-stained one's not validated for molecular tests. And some practical points, when you send samples for these extrapulmonary samples, when we don't receive adequate amount, we tend to send them for culture because they are precious samples rather than going for GeneXpert. So make sure you send adequate samples to NTRL if you want both tests. Even these tissues, if they are grossly blood-stained, we can't perform GeneXpert. So it will go for culture. So just for completeness sake, I'm mentioning, putting this slide. So this is not available at NTRL, but it is mycobacterial blood culture, restricted to investigate special conditions like tuberculosis infection in bone marrow and disseminated atypical mycobacterial infection. For example, mycobacterial avium complex infection in HIV patients. So because we don't have this, that's why we the bone marrow is cultured in solid culture at NTRL. So some few words about pediatric TB. So worldwide, there's a large case detection gap in children. That is explained by because there are challenges with specimen collection in children because it's and also the paucibacillary or less number of bacilli in children. So that the WHO has identified it as challenges. So therefore, they recommend expert ultra should be used as the initial diagnostic test for TB in children. So these are the respiratory samples, the samples to detect pulmonary TB in children. Induced sputum, gastric aspirate, nasopharyngeal aspirate, and stool is also, there's a recommended method by WHO, but we have not started it yet at NTRL, but hopefully in the future because it's less invasive rather than getting a gastric aspirate from a child. So please remember when you get a sample with difficulty from a child, do send it for more sensitive tests like gene expert. Don't send it for like AFB in this non-sterile containers. And finally, some a few words about diagnosing TB infection or latent TB infection. So this, as I said earlier, TB infection is a state of persistent immune response to microbacterium tuberculosis antigen with no evidence of clinical manifestation of TB disease. So the soft copy or the e-version is available in the NPTCCD website. This was developed by the program and the Sri Lanka College of Pulmonologists. So diagnosing LTBI or latent TB infection or TB infection, there is no gold standard method. So what is important is to rule out the active TB disease. So proper sample collection and appropriate selection of laboratory investigation is important to diagnose LTBI or latent TB infection. So why it is important to diagnose latent TB infection? As I said earlier, LTBI can develop into TB disease and those people can become infectious to others. So that's why it's important to identify and give prophylactic treatment. So all these things available in that guideline, available in the NPTCCD website. So these are the tests available to diagnose LTBI, tuberculous skin test or MAN2. We know that it's well established and available in chest clinics and hospitals. And these new things are these interferon gamma release assays or IGRAs. And there are newer MTB antigen-based skin tests, which are also done similar to MAN2. So the advantage in the MAN2 or the tuberculin skin test, we used purified PPDs. So they are like heat-killed M. tuberculosis bacilli, but because of, so they are like, there can be cross-reaction with BCG and other non-tuberculous bacteria, reducing the specificity in this tuberculin skin test or the MAN2 test. But for IGRAS and this newer and TB antigen-based skin test, what they use is ESAT6 and CFP10. They are antigens found in M. tuberculosis, but not present in BCG and other most species of non-tuberculous microbacteria. So they are specific. So these are the IGRA. So this quantiferon TB Gold Plus was recently established in NTRL. But there are some guidelines. They are not freely available actually. So it's just established. So there are supply issues, but we are planning to continue that. So it's TB quantiferon TB Gold Plus. So this is on the right side. It's another test it's a type of IGRA assay as well. So these are the newer skin TB antigen-based skin test I mentioned. So SciTB and these other two are again these ESAT6 and CFP10 they use, but all these tests are done at the same way as MAN2 is done, the MAN2 method. So there had to be 2 visits, first to inoculate, then within 48 to 72 hours, the patient has to come back to read the results. So that is the disadvantage, unlike in IGRA where there are only 1 visit. So this is these are the where there can be false negative skin testing. So can be with the technique, can be with the biological factors. So that's why it is important to have a good staff training, standard method. For the poor administration technique, improper reading, those things can give rise to false negative results. And also the biological factors like active TB disease, especially more advanced HIV, immunosuppressive conditions, HIV, those things can give rise to false negative results. So this comes to end of my talk. Actually, so I have spoken about a lot of diagnostic tests and what the take-home message. I believe what is important is there are newer sensitive rapid diagnostics available, but the main important thing is the clinical suspicion and the early rapid diagnosis and initiation of prompt treatment, because with prompt treatment, appropriate treatment, by 2 weeks, the infectivity of the patient, we can the patient will no longer be infectious with roughly about 2 weeks of appropriate treatment. So that's so with the available methods of testing, the clinical suspicion is the most important thing. So these are my references. And the WHO is going towards NTB target by 2035. So we are planning to go towards that, but needs the support of all the clinicians and the community. Thank you.
Thank you very much, madam, for that informative lecture. We have covered all the bases regarding the diagnosis of TB. We have several questions in the chat box. One has asked, is ADA a good test to rule out or diagnose TB from peritoneal or pericardial fluid?
So it is mainly ADA's this pleural fluid ADA they talk about, but it's not that, as per my knowledge, it's not that good method.
Right. Okay, madam, there's another question. Standard definition of pan-resistant TB.
Pan-resistant TB. There is no definition as pan-resistant TB. So as I said mentioned in my slides, so there can be drug susceptible TB and rifampicin resistance or MDR. So there is step by step, there are like MDR is when isoniazid and rifampicin both resistant. So this maybe this doctor is speaking about the XDR. So as I said, in XDR, resistant to rifampicin, isoniazid, and fluoroquinolone, and also one of the group A drugs, that is linezolid or bedaquiline.
Right. Okay, madam, there's another question. I think you have answered it. What is the gold standard TB test? You mentioned as the culture.
Yes,
And the
and take it as liquid culture.
yes. And the final question, madam, in drug susceptibility testing, do all first-line anti-TB drugs check? In drug, yeah.
Yes. So we test this. We at NTRL we do this solid. We were doing solid DST for solid culture based drug susceptibility testing. So we were testing so we were testing the streptomycin as well, but that is no longer in the treatment regime. Streptomycin, ethambutol, rifampicin, and isoniazid. The pyrazinamide was not tested because this it was not stable to test. The compound is not stable to be tested, so it was not tested. With the liquid, we started liquid drug susceptibility testing very recently for the extrapulmonary sample. We'll be showing a liquid DST or the liquid drug susceptibility testing. So with that, the 5 anti-TB drugs, the sensitivity of 5 anti-TB drugs will be available. Pyrazinamide, rifampicin, ethambutol, streptomycin.
Right. Madam, there are another 2 questions. One is, what is the best test to diagnose TB in pericardial fluid?
So as I said, the best is the gold standard is the TB culture. But if not blood stain, we can do gene expert as well. If not blood stain. So in the programmatic perspective, it's first line, these molecular tests are the first line. That's a programmatic view they talk about, preventing spread. So, but in these clinical situations where we need a diagnosis, so as I said, pericardial fluid is a pressure sample, if not blood stain, we will do gene expert. If blood stain, it will go for liquid culture.
Right. Okay, madam, one final question. When gene expert shows very low level and all 3 AFB negative, can we diagnose TB?
So gene expert is recommended for when the AFB is negative. So gene expert is more sensitive. So with the, as I said, it depends with the result. So definitely, when there's a trace result with sputum, the WHO recommends to correlate with the clinical, like with the clinic, whether there had been a past TB infection, those things. But when the sputum is negative, when gene expert is positive, most of the time it's yes, with the chest X-ray and those things, we can diagnose. The question should be more specific. What level of like the gene expert result? As I said, it can be high, medium, low, very low, trace.
Right. Okay, so that's it. Thank you very much, Dr. Wathsala Dayanthi Galagedara, consultant microbiologist, for joining us on a Sunday morning to conduct your timely lecture, madam. Thank you very much. It was very informative and was a very timely lecture regarding a very important topic, the update on diagnosis of tuberculosis. And I thank all of you for joining us today, and I invite you to join in the next session as well. The link for the CPD certificates and the CPD points are put in the chat box. Kindly follow it. If you don't receive the certificate today, you will receive in the oncoming days, because we are only issuing about 100 certificates per day. So don't keep a question about it. And thank you very much. Thank you all. Hope you have a good day.